Thanks for giving the opportunity for me to talk here. I was presented the opportunity just late yesterday, but it's always a pleasure to give a talk. So it's a little bit different story that you have heard so far. It's not that much focused on the cancer, but just thinking, one step further from the precision diagnostics to I would say genomic guided public health solutions. And I will present some aspects of Estonia, what we have done there, and what's the potential for a healthcare system when a lot of genomics data is available. So while you all have heard about Estonia, some small facts. It's a rather small population or country in the northern part of Europe, so only 1.3 million citizen, country the size of roughly Netherlands, but it's really, really small. And but what we are mostly known of is actually being one of the most digitalized societies in the world. So we have a lot of things done electronically, and this has also led to some of groundbreaking technologies and services, like everyone is using Skype, so what was written by Estonians, and the new couple of IT unicorns rising from Estonia is like the TransferWise for bank transfers, and Taxify, it's a competitor for Uber. So this all, what I'm going to present actually grows out from this excellent IT environment. So before I go into the genomics, some background more. So all Estonians have a 9-digit personal identification code that they get at birth, and so all the database is actually where the data recorded about the person all have the same code, so it's very easy to connect data together. And actually, it's forbidden by the government to ask the data twice if they should actually have it in the databases. And everyone also has a mandatory ID card, which is valid for giving signatures, and we are using it for signing documents, electing our government. And only 3 things you cannot do with your electronic card is getting married, getting divorced, and buying land. Everything else you can do electronically. You can even become an Estonian e-resident, so actually you could also do all the things, except you cannot vote, but all the other things are for you. And also it's good, all the citizens also have a government-provided email address, so basically it's possible to just approach the citizen very, very easily. And on this platform, a lot of services have been developed or set up, like e-tax or e-police, e-school, so you can just electronically check on everything, and it takes me literally 2 minutes to file my taxes and 3 days to get the money on my bank account. Where in the US, I have to spend a lot of funds just to hire a tax accountant. And as I said, like this, as we have this unique ID code system, there is also a lot of, or all the health service providers and databases are linked. And so all the data moves around very, very smoothly and makes the use of electronic data, including genomic data, extremely easy. And this is just like the sum of the landscape, has been the space or base in introducing e-services in Estonia. It's like e-tax board, m-parking, e-voting. And about what is interesting in e-voting, 1/3 of all votes come electronically, and then you think that those that are voting are the young hipsters, but actually no, the largest fraction of e-voters are actually retired citizens, because they're just too, not so able to go to the voting station, and it's much easier for them to do it at home. So it's also some interesting things there. And also we have e-prescriptions, and it only took, I think, 8 months that almost all prescriptions were electronic. So these days, 99% of all prescriptions are electronic. So no need to go and see your doctor to get your prescription renewed, for example. And as always, it's very hard to be a known prophet in your own land, so you are looking for where others are providing recognition. So President Obama, when visiting Estonia, said, like, I should have called Estonians when we set up this bloody healthcare website that failed. And there's also Eric Lander, the person who was involved in human genome sequencing. He has recognized that there is a great potential to use Estonia as a model for implemented genomic medicine on a global scale. And there's also director of the National Institute of Health. It's also that recognizes that some countries, mostly in Europe, are actually doing much better than they're doing in US. So this all gives us more enthusiasm to move forward and really try to some new models in the healthcare. So I come from the Estonian Biobank, which is a collection of data, both biological data and health data, for 50,000 Estonians. And 50,000, small number, but it's 5% of the population. And as we have a very forward-looking consent and law, we can actually recontact the patients. We can get information from basically every database you can imagine, and some that you cannot even imagine. And we can also, the law actually requires and provides the guidelines how the genetic information should be given back to the citizen. So it's quite unique that a biobank gives genetic information back to the citizen. And so how it all goes is that we have a data collector office. People come to answer a questionnaire. Sample is taken, then the data is pseudo-anonymized in the high security era, and all the data goes into database where it's open for academic research, collaboration with private sector, but also use in the healthcare and developing products and services. And then to the law and consent, we can actually regularly retrieve data from health insurance or registries or hospital records, so building actually an rich data set for research. And this is just to demonstrate that things happen really regularly. So for example, we want to get the last year's health insurance data. We just encrypt all the 50,000 personal ID codes, send it over email to the Ministry of Social Affairs. They decrypt it, they retrieve the data, decrypt it again, send it back to us. We put in the database, takes on average 2 weeks, or could do less, because it's, as I said, everything is already digitalized, automated, very, very smooth to do. And what's the infrastructure? We have both DNA and plasma for the 50,000 participants, so enables a lot of high quality research. And this is just one of the examples. What we can put together is like a health trajectory, so from birth till current day. So it's actually recruitment is somewhere in the middle, so we can get all the new events that happen to the person just from the registries. And I know that we have 1,500 incident cancers, for example, after joining the biobank, which enables us to look for biomarkers for the future, hallmarks of cancer, either from DNA, from plasma, and the same trajectories could be done for medication use, clinical labs from the hospitals, you wish. And then we have generated quite a lot of omics data, so focus on genetics. So we have 2,500 full genomes and 2,500 full exomes, and all the 50,000 actually have been now genotyped with the genotyping array, so we can play around with the genetics and check what is predicting what. And what always is important to have the technology in-house, so you can adapt to new approaches to genome analysis and have the know-how how to use the data and what are the limitations of the data. So now the question is like, is this information enough to do something on the healthcare level? I don't mean precision diagnostics for cancer, but something on the prevention side of things, to keep people healthy, because it's much cheaper for the healthcare system to keep people healthy than treat them. I think it's quite obvious we don't need a trial for that. So a small cartoon, let's say a person born he or she has a certain background on genetic risk. Either it's a bad mutation with high impact, like BRCA1 and 2 mutation for breast cancer, or it's just, let's say, a background distribution of adverse alleles for prostate cancer or type 2 diabetes. But everyone has it, and it has a normal distribution in the population. So some people have a huge load of bad alleles, and some have almost nothing. But as we age, we start to accumulate all kind of risk factors. In the school, we sometimes try a bottle of beer or smoke behind the school building, and the things get worse. While we age, go to the college or university. Don't do sports anymore. So the risk factors accumulate. At some point, our couplet of risk tolerance is full, and we develop the disease. And when we know our background genetic distribution, we potentially could act on our lifestyle and then try to be healthier longer. And this is just to demonstrate that when stratifying our patients or participants by their genetic background, and this is example for type 2 diabetes. So at recruitment, no one had diabetes in our study cohort, and then we followed up them 6 years, and then we stratified our cohort by the risk profiles, top 20%, bottom 20%, and then if you look, you can see that there is almost five-fold difference between the bottom risk profile and the top risk profile. So demonstrating that indeed, if we could target the top risk group with some preventive measures, we could postpone the disease onset in those citizens. But it's also about support. You can have innovative things, but if everybody are against it, including citizen, doctors, and policymakers, you cannot really implement anything. And so what we have done over the years, we have actually followed up the public opinion and awareness about this kind of genetics and understanding in genetics and opinion towards the biobank. And in the latest, actually it's a little bit outdated number, but it goes on the same way. So on average, 70% are in strong support in the genetics in healthcare and genetics in research. And there is roughly 25% that need more information, but in general, they are positive. And then there is like this 1 or 2 or 3% that are against it. But if you ask, there is always someone against everything, so it doesn't matter what you're doing. So it's hard to say if they are against the genetics, or they are in general against anything. So, but the message is that it has a strong support, so we can do this kind of thing. So the vision for future, what we see is that actually the genetics and all this big data should be in a kind of virtuous circle of data where the treatment information gives you information how successful is the treatment or medical actions, and you can then change decision processes and again use this data to make further research discoveries. And this is just like a small example what kind of data we are giving back to the participants here on the small trial. So this is, sorry, it's in Estonian, but it's about type 2 diabetes, and this is basically representation of your genetic risk on the scale of 10. And this person, is lucky, doesn't have almost any genetic risks, and if this person keeps his or her lifestyle in check, there is no risk for diabetes. And here I say this score is actually uses, I think, 8,000 genetic polymorphisms from the genotype array, so it's not based on 1 or 2 mutations. And we also look into the pharmacogenomics. So what are the common or rare mutations that one has that could have an effect not again on cancer treatment, but rather this everyday life medications that you may come across. And we are also doing or just finished a study, Genotype-first approach, where we took the deep genomes and deep exomes, so 5,000 roughly, and identified all individuals who carry the familiar hypercholesterolemia mutation in 3 genes. And this is demonstrated on the small Estonian map, so we have 50,000. Some of those have full genome data available, and then the ones in the red are carrying the mutation. And then what we did, we called back those individuals, gave them genetic counseling, medical counseling, and then approached family members in the cascade screening way and offered the same way. And what we find was quite surprising. The first columns, it's like 68% didn't know that they have anything wrong with their LDL cholesterol, and only 32% had already some medications. But after the visit, we actually were able to, change this dramatically, so that the much more people now were on treatments, and the ones that actually had a very moderate dose, they were actually reclassified to have a much higher dose. So it's also demonstrates that sometimes, or I would say almost always, it's good to know the background genetic information prior the onset of the disease, and knowing the genetics, you can actually act on the health risks without without the people knowing their, for example, lipid levels. So, and there is a roadmap for personalized medicine in Estonia. So we have generated some some sequence data, and we have doing clinical pilot studies on cardiovascular disease and breast cancer. And actually what is happening this year, we are recruiting additional 100,000 citizens and get their genomes genotyped with array enhanced with imputation, and then generate such reports that I presented, and those will be put into the healthcare system by used to the doctors. And we're also actively looking for collaborators, both academic and industry, and both on this IT side, but also biotechnology or pharma side. So in summary, Estonia is a great place to try this exercise of personalized medicine. We have all the IT infrastructure to do it. We have the genomic tool set and the knowledge how to handle it, also the scientific and medical expertise there, and people are extremely interested in personalized genome-based healthcare solutions. So this is all I wanted to present. So this is our small team who is working on this, and those are the funders and supporters from the Estonian side. So happy to answer any questions you have.
Thank you.